Hello, everyone. I'm Dr. Bill Beakey on behalf of our staff here at Professional Co-op. Welcome to today's webinar with our good friend, Dr. Brandon Lundell. This is one of a great series, our master series. There are many other iterations of it, and the previous ones are on our website for you to view at your leisure. We hope you will take the time to do that. They've all been really awesome. We've just had a great bunch of speakers, so please avail yourselves to this. It's absolutely free to our members. You can watch them at your leisure, and we're very happy to have so many of you today watching in person because we think that's always the great way to do it. Dr. Lundell has done a number of other webinars for us. Those videos are all on our website. Please do take a good look at those. He always does an excellent job. He's a great researcher. He spent 15 years, more than 15 years in practice. He's a truly integrative practitioner who always does what's best for his patients, and he assesses patients through laboratory testing, through physical assessment, and also through really solid history, which is very important as well. And his style is truly integrative. He takes into account everything that Western medicine may have to offer, and also combines it with the most effective natural first therapies. He's developed a great course of his own called Nutritional Pathology. You'll be able to find this on drbrandonlundell.com, and he's going to tell you a little bit more about that later. I promise you it's a tremendous course with lots of different avenues of evaluation and treating all sorts of tough cases. Dr. Lundell has also served as an adjunct professor at Southern California University of Health Sciences, where he developed and taught a functional medicine program for doctoral students. He also teaches for many organizations, including and especially the DAPSI group, which is the American Chiropractic Association's Council on Internal Nutrition. So the concept of internal medicine will be much in play in today's lecture. He serves as an advisor for nutraceutical companies. He's designed and formulated a number of different products that are used worldwide by many thousands of patients. Dr. Lundell's contact information will be found at drbrandonlundell.com. And I think we will just go right into our lecture here. Dr. Lundell, thank you so much for doing this, and welcome. And thank you for all your previous efforts here with so many good recordings that are available.
Yeah, thank you, Dr. Beakey, and thank you to Professional Co-op for putting these together and offering these. It's truly a unique venue, a unique group of presenters with a lot of great information, and I'm very grateful to be part of it. Very proud to be part of this. So thank you very much for having us, and thank you very much for putting this together. This is a lot of work ongoing, and a lot of different doctors doing this, and sometimes that can be difficult. So so thank you for offering the opportunity for me to come and share some knowledge with all the Professional Co-op family, and again, thanks for offering the Professional Co-op services. I use it all day, every day, and we'll go over some of my tests that I run on a daily basis in this lecture. So yeah, thank you very much.
Yes, folks, I will personally guarantee a great time and a great lecture today. Everything Dr. Lundell does is extremely well researched and well considered through his clinical experience. So we're going to get great information about autoimmune. There's much more and more of this autoimmune stuff constantly flowing into us. So I think this is a very important topic, and this is why we were so excited to have this particular presentation. So I will turn it all over to Dr. Lundell now, and enjoy, folks.
Okay. All right, thank you. If you do have questions, if we have time at the end, you can type your questions in, and I'll try to get to the questions at the end. So so we'll just jump right in. So we'll talk today about key strategies for supporting mitochondrial health, especially in autoimmune. I'm in my 17th year of practice, and I've been doing functional medicine from day one. And this is something that I have sort of titrated out through all of the knowledge and study and clinical practice that I've had over these years, that the more and more I see, the more I research, so much of what we treat on a daily basis is what we can call a mitochondriopathy, things that affect the mitochondria. How many times have you heard in your practice, you know, complaints about fatigue, complaints about energy, complaints about brain fog, you know, and also the autoimmune. And we'll get into the autoimmune component. I have a whole, 12-hour lecture on autoimmune because it's a very, very big topic. And as Dr. Beakey mentioned, it's in my nutritional pathology and functional medicine certification course. So I'm just going to give you a basic overview of that today and how we approach that in my clinic and with my students. But it's really important, and then relating that to how it affects mitochondrial health, and vice versa, how mitochondrial health affects autoimmune. So standard disclaimer, none of this is intended to diagnose, treat, or cure any diseases. It's up to you to take this information and use it to the best of your discernment and wisdom. So this is a copy or a color EMG, electron micrograph of mitochondria. So it's a pretty cool picture there. So we'll discuss the relationship between mitochondrial health and autoimmune disease. We'll have a quick review of what cellular respiration is in the mitochondria, because that will help us direct our therapies if we understand the cellular respiration. One of the things that I'm really big on in my classes and my teaching is that we have to understand at a deeper level what's happening. I can give you protocols, and that's great. I can give you a protocol in 5 minutes and you can memorize that and you'll be a good doctor. But great doctors know why. Good doctors know what to do, but great doctors know why. What is really happening? Because not all patients are the same. Not all patients will fit into a protocol. So you can take this information and apply it to each patient. We'll talk about protecting and restoring mitochondrial health as a clinical tool for many diseases, not just autoimmune. And we'll talk about specifically what we want to do, what I do with nutraceuticals and lifestyle to restore the mitochondria. And we'll talk about some of the assessment of mitochondria. So we know autoimmune is a lifestyle and an inflammatory disease. I like this picture because it just sums up how poor diet, biochemical hormonal imbalances, pathogens, leaky gut, stress, medical and dental, infections create this chronic acute inflammation or chronic subacute inflammation. You get the acute inflammation, then you get subacute inflammation. And this is oxidative stress and cell dysfunction, this what we call para-inflammation. And it leads to all types of issues. So when we look at the right and we look at, the inflammation, and we look at infectious diseases, heart disease, cancer, obesity, Alzheimer's disease, all of that actually has mitochondria and mitochondrial damage, not as a secondary issue, which it can, but as a primary issue. So what I'm saying there is that the mitochondrial damage is what triggers much of this chronic inflammation and chronic reactive oxygen species and tumor necrosis factor alpha and interleukins. It's actually the body's response to those mitochondrial proteins and damage that's happening that triggers the autoimmune and obesity and type 2 in many different areas. So we know autoimmune disease is on the rise, and what medicine talks about autoimmune is a description of symptoms. So for instance, someone may have all of the positive serology of lupus or rheumatoid arthritis, but if they're not expressing symptoms, then medicine would deem them disease-free. And so what we do in functional medicine is to look at the labs and use that as a not only understanding the root causes, but also predictive. And we'll go over some studies today that show how this is used in a predictive manner. And quite amazing how some of these basic blood tests that we have can quite accurately predict autoimmune disease down the road, even if there's no symptoms happening. So a brief review of the autoimmune triad. Again, this is a 12-hour lecture, but when we think about autoimmune, it's understanding that there's three main components to autoimmune, and these three components are almost, if not always, there in some degree or form or fashion. So the first thing we see is leaky gut, and this is something that I really discovered, and the research really blossomed about 10 years ago. University of Copenhagen, just all of these studies showing that leaky gut actually precedes autoimmune disease and is a required prerequisite for autoimmune disease formation. So intestinal barrier dysfunction, dysbiosis, that chronic inflammation, the activation of the interleukins and cytokines, and the microbial endotoxins and byproducts that leak into the bloodstream, that trigger inflammatory responses, that then you have cross-reactivity with your own tissues, that specifically mitochondrial proteins, which we'll talk about, that trigger mitochondrial damage. So leaky gut really is one of the main causes of mitochondrial damage. And we can say it another way: the main problem, the main issue that leaky gut causes is mitochondrial damage. We can trace pretty much everything back to the mitochondrial damage. And so the reason why I wanted to talk about this today is a lot of practitioners are doing the right things. They know leaky gut is associated with autoimmune and, environmental triggers. This is nothing, new or groundbreaking necessarily. But I think that the treatment and the assessment of the mitochondria sometimes gets missed. The emphasis on the mitochondria sometimes gets missed. And I think that that's why we have pretty good success with autoimmune disease in this clinic. So we also have the genetic background. We know that there's a genetic haplotype that predisposes one to autoimmune disease. A lot of that has to do with methylation, though. If you have acquired, both genetic and acquired methylation issues, then that's going to contribute to more predisposition of autoimmune. What do I mean by genetic and acquired? So methylation issues is not just a genetic thing. So if you run SNP testing and you automatically assume somebody has methylation issues, that is incorrect. Or if you incorrectly assume they don't have methylation issues based on their SNP testing, that's incorrect as well. So SNP testing is important to determine predispositions and where to look, but we have to run phenotypical tests, phenotype tests. Are methylation issues actually expressing? The main ones that I run for checking that is homocysteine. You can also run SAMe and look at their SAMe levels, and you can of course do B12. With Professional Co-op, I have a B12 panel. You can write this down, or if you have any questions about it, Dr. Beakey can probably give the codes, the test codes in the chat box there. But I've got a B12 panel, a methylation panel that will assess B12 levels, folate levels, homocysteine, intrinsic factor, those things. That is going to tell you more about the person's acquired and genetic expression of methylation issues. But that has to be addressed, as we all know. It just needs to be addressed specifically to the patient. You don't want to do it, again, based on just the SNP test. And then there is the environmental trigger, the third thing that comes along, that the straw on the camel's back that pushes the person over into an autoimmune disease. That can be stress. It can be very stressful, prolonged stressful events, infections, again, an infection in the gut or infection in the mouth. Nutrients and diet can do that if the diet's way off. Of course, toxins and toxin exposure, like mercury or heavy metals or things like that. So, and these triggers aren't always quick. These triggers can be years or decades before they finally tip the scales into autoimmune. So again, this is, IIP is the name for leaky gut we use, increased intestinal permeability. And then these environmental triggers can be, again, herpes, Lyme, H. pylori, candida, toxoplasmosis, cytomegalovirus, again, Epstein-Barr. So these are things that we also want to address. And I believe, is it next month? Dr. Hedberg is going to talk about infections and how that relates to autoimmune disease as well. So, so look out for that one. That should be a good one too. Assessing the viral burden and the toxic burden on a patient is really, really important. So, we call that sort of the viral load. So this is a good study, chronic fatigue that we look at all the time in our patients. This is kind of a breakthrough in autoimmune disease theory. So in this study, metabolic profiling indicates impaired pyruvate dehydrogenase function in myalgic encephalopathy, chronic fatigue syndrome. So what these studies are showing is that we actually have autoimmune antibodies to the mitochondria, and more of those antibodies will become available, but we do have many now. We have smooth muscle antibodies, we have antimitochondrial antibodies, and we have antinuclear antibodies, which also cross-react with mitochondrial antibodies. If someone has a positive ANA, doesn't mean they have autoimmune, but it does mean they're having active mitochondrial dysfunction. So let me say that again. If ANA is positive at any level, it means that that patient has active mitochondrial as well as DNA damage due to this autoimmune and chronic inflammation. Doesn't mean that they have a full autoimmune disease yet, but it does mean that this is the issue that one of the issues that needs to be addressed. So it's interesting that if we can develop, and they are developing more antibodies to test for mitochondrial damage, then that gives us a little bit better confidence that that's exactly what's happening. And why is that important? Why is it important? I've had students ask me this. If we see autoimmune disease, all autoimmune disease essentially is this triad, and we're going to treat the triad anyway, why is it important to know which tissues are being damaged? Well, the answer is kind of obvious. We want to support those tissues specifically if they're actively being damaged. So, so this is interesting. When the mitochondria is not functioning well, and we'll get into a little bit review of what the mitochondria does, and obviously it's the pyruvate. It's making ATP through through glucose metabolism. When that gets impaired, the peroxisomes and part of the mitochondria will switch to amino acids for energy. Specifically isoleucine, leucine, lysine, phenylalanine, tryptophan, and tyrosine. So that can enter the oxidation pathway as acetyl-CoA. So that's an alternate fuel as the mitochondria start to get damaged. This is one of the reasons why paleo diets have been pretty successful with autoimmune disease, because you're providing more substrate for the mitochondria. So branched chain amino acids specifically can be very, very, very helpful in chronic fatigue syndrome, in almost all autoimmune disease that's affecting the mitochondria, and any mitochondriopathies. And so toxic lead or toxic metals affect the mitochondriopathy and dysbiosis, those kinds of things. So really, that's pretty fascinating that we do know this. So most of my patients respond well when they have a mitochondriopathy to increase branched chain amino acids, and you can also do more N-acetylcysteine, more tryptophan, more tyrosine, those kinds of things. And it makes sense that if tryptophan and tyrosine are low, then you're going to have downstream mood problems and brain and thyroid issues as well. So which almost always accompanies autoimmune and specifically chronic fatigue. Yes, if we understand the biochemistry of making energy molecules, then possibly supplements that restore low levels of energy molecules that are measurably low are a theoretical way this research could point to treatments. And yes, it actually is a very good treatment. So, and I would add reversing the autoimmune by healing leaky gut, addressing the infections, nutrient deficiencies, practicing relaxation response, mindfulness, inflammation, methylation, everything that we talked about, and the mitochondria. So the rise of mitochondria in medicine, this is another good study, once considered exclusively the cell's powerhouse, mitochondria are now recognized to perform multiple essential functions beyond energy production, and it impacts most areas of cell biology and medicine. For instance, mitochondrial proteins have been discovered that trigger or stop autophagy in the cell. So if the mitochondria isn't working well, then it can actually trigger either too much autophagy and the cell becomes lysed, or not enough and the cell becomes lysed because of the toxic burden that overloads it. It will also affect methylation and DNA repair and clock genes, which is why understanding the health of the mitochondria is so important. So, and it spans genetics and oncology and neurology, immunology, even emergency medicine. So this is a diagram just showing that, we have the proteome, the metabolome, this bottom tier here, post-translational modification, mitochondrial DNA, the OXPHOS is phosphorylation, oxidative phosphorylation right there in the middle, transcription regulation, hormonal receptors, developmental epigenetics. So certainly one of the things that I concentrate on a lot of my practices is preconception planning. And if the mother is going in with any kind of mitochondrial issue, then the developmental epigenetics are going to be severely altered in a negative way. So all of that is facets of mitochondrial and cellular function, not just ATP production, which then affects the neuroendocrine, the immune and inflammation, metabolic, central nervous system, which can then, in the right-hand corner there, affect cognitive issues, diabetes, mortality, functional limitations, aging, all of that. So truly, mitochondria is kind of at the epicenter and the nexus for health and disease. And again, this isn't anything new that we haven't heard, but in my experience, it's not emphasized. It could be emphasized a lot more in clinical practice. So this is one of the predictive studies I was talking about, prediction of autoimmune diseases by targeted metabolomic assay of urinary organic acids. What this means is that there's certain organic acids that we can test that not only look at mitochondrial function in the TCA cycle, but it will predict, like it says here, artificial neural networks and binary logistic regression resulted in the highest predictive accuracy scores, up to 75% prediction rate with running these organic acids and then seeing down the road autoimmune disease developing. So and it's early diagnosis as well. These organic acids, which you can run through other labs, Professional Co-op doesn't have organic acid testing, urinary organic acid testing, but other labs will. So 4-hydroxyphenylpyruvate, 2-hydroxyglutarate, some of these can be run in through other labs, but that is we do that, and we can use that to see what the state of the mitochondrial health is. In this study, oxidized mitochondrial nucleoids released by neutrophils drive type 1 interferon production in human lupus. So what this is saying is that the mitochondria that get damaged in the lymphocytes, specifically the neutrophils, when that mitochondria is being damaged, then that's going to trigger more lupus, more autoimmune, because those mitochondrial proteins that get released, with the uncoupling of the mitochondria, and not even uncoupling, but the dysfunction, the parafunction of the mitochondria release certain proteins and organic acids that will cause the lymphocytes to malfunction. And we see this in COVID cases as well. That's why leaky gut and mitochondrial health are really the greatest predictor. So when we look at all the comorbidities that are associated with, COVID and other immune diseases, then it comes back to the mitochondrial health, and that's what we really need to be focusing on and centering on, is how do we support the mitochondrial health. And all of these treatments get around it and are treating it at some point. The zinc and vitamin D, all those are really important, but ultimately it's helping the mitochondria that those things are doing. So mitochondria is a huge target. It is obviously it's very oxidative, and so any type of redox imbalance that a person is experiencing is going to affect the mitochondria first. If you don't have enough glutathione, if you're not making enough glutathione and you're not recycling it, if you're not methylating properly, if you have nutritional deficiencies, if you have too much inflammation and stress coming in from leaky gut and environmental toxins. So it's interesting though, in these studies, what it's showing is that environmental pollutants actually aggregate around and within the mitochondria. This is pretty groundbreaking. We used to think it gets stored in fat cells, and it does, but it's actually within each cell. It's the highest concentration around the mitochondria. So when we start detoxing, that's one of the reasons why people can feel tired, is because it's going to affect the mitochondria at first, because you're pulling those out, you're stirring those up, and the mitochondria can get damaged in that process. But it's a bit like pulling the arrow out of the wound, so it needs to happen in order for healing. The effects in this study too, the effects of environmental pollutants on cellular iron homeostasis and ultimate links to human disease. Environmental pollutants, interestingly enough, can complex iron, and obviously there's iron in the mitochondria for oxygen, transfer. But the environmental pollutants can complex iron through electronegative functional groups containing oxygen, nitrogen, and sulfur. So cellular exposure to these chemicals or their metabolites cause a loss of that functional iron from intracellular sites. So toxins will bind iron and specifically then damage the ability of the mitochondria to make energy. So just an interesting mechanism. It doesn't mean that the person's necessarily going to be iron deficient in this case. It just means that toxins, and this is why people can still exhibit symptoms of iron deficiency and fatigue when they're not iron deficient on their blood, because the body's actually complexing it and making it unavailable. So just interesting to understand that. So let's review just really quick before we get into ways of supporting the mitochondria and ways of diagnosing it as well. So there's two major pathways of energy production in human cells, and it's ATP, so the citric acid cycle there, from glucose down into the citric acid cycle or tricarboxylic acid cycle into pyruvate and glycolysis. But then we have this NADP into NADPH, which is important in fatty acid synthesis, glutathione reduction, other reactions such as detoxification. So the mitochondria is important in actually recycling glutathione, in recycling fatty acids. Almost every case of non-alcoholic fatty liver disease or steatorrhea is a mitochondrial issue at its core, specifically the mitochondria in the liver. And that's a whole nother thing, but I go into that in my courses as well. I have lots of case studies of complete reversals of fatty liver and autoimmune diseases and mitochondrial issues. So this NAD is really important for energy, and people are getting NAD IVs and taking NAD, which is really important. But we need to be able to make it and recycle it, and that is the mitochondria. So if somebody feels really good on more nicotinamide adenosine diphosphate or or NADH, and they're taking IVs, then that's actually a clinical diagnostic for mitochondrial issues. The other thing that's really important is that the mitochondria, through ribose, through the formation and utilization of ribose, makes nucleotides. So our very genetics are dependent on the mitochondria. Without the mitochondria functioning well, we can't repair our own genes. We can't synthesize those nucleotides that are needed. And this is all done in the pentose phosphate shunt. So, and all of this is very much dependent on, B vitamins and CoQ10 and proper nutrition, vitamin C, those kinds of things, and also supplying ribose, which we'll get into. So this is just another example. We don't need to go into, all of the different oxidation of fatty acids and glycosylation, but these are some of the things that we can test for, though, in the organic acids. Again, ribose is the substrate for ATP. Without ribose, the mitochondria cannot make ATP. So we've got the phosphate group plus ribose plus adenosine, and then you get the phosphate groups attached to the ribose. So ribose is made endogenously only through the pentose phosphate pathway. So if the mitochondria are not functioning properly, then we can't make ribose, then we can't make ATP, and we can't make the nucleotides, and we can't recycle glutathione. So it's ubiquitous. Its effect is ubiquitous. So our nucleotides, even other coenzymes, our DNA and our RNA, all of this dependent on the pentose phosphate shunt. Also making aromatic amino acids. And again, this is why supplying somebody with a mitochondriopathy with these aromatic amino acids that we saw before in the study is so helpful, because the body just isn't making them. It's having to utilize them for energy instead of producing these aromatic amino acids for use in other systems. G6PD is the dehydrogenated form to form ribose. So if someone has a G6PD, the enzyme deficiency, then again, they're not making enough ribose, and they're at least they're suboptimal. They may not have any clinical symptoms if everything else is healthy, but these people could probably benefit from some ribose. Why do we run G6PD? It gives you a clue as to the mitochondrial health and all the genetic issues for G6PD. If again someone is deficient in G6PD, and then we know that they have a mitochondrial issue, or they're susceptible to it. We also do this because if we do IV vitamin C, something highly oxidative, these people are susceptible to oxidative stress. So then we want to provide more oxidation, even if you're not doing IV vitamin Cs. But if you are doing IV vitamin Cs, it's well known that you have to run a G6PD. If you're going to be over, in my clinic, if I'm going to do over 5 grams, then I want to do a G6PD. But I do G6PD in a lot of patients just to test their oxidative strength genetically and see where they're at with that. So supplementing ribose, most people don't know that supplementing ribose preserves that ATP, produces more NADPH, reduces the glutathione. So that is another issue to look out for. Another clinical pearl, I'll tell you, a high RDW in a non-menstruating female is another clue. So if somebody has high RDW, what that means is even if they're not, even if their hematocrit and red blood cell levels are fine, but if they have a high RDW, that's a clue for you that they're undergoing a lot of oxidative stress. This isn't always the case, but it's just another clue. So I have a lab manual that I've written, and you can go to my website to download it, Dr. Brandon Lundell. So the lab manual covers many of these, and the way I teach laboratory medicine is you want to understand what this analyte is saying. Don't just memorize, oh, if it's high, then you give these supplements, or low, you give these supplements. That's actually one of the worst ways of learning blood chemistry. You want to learn what the analyte is and what affects it. And so I go through what the analyte is so you understand it and all the different things that affect it so that you can come up with a true picture. So I like the word diagnosis. I was a Latin major in college, and so I love the study of words. Diagnosis, dia, comes from the word to throughout, the whole, right? Like diameter is the whole meter, it's the whole circumference. So, and gnosis means to know. So to make a true diagnosis means to know something from all angles, from 360 degrees. And this is how we do that. We run the labs and we understand, we start to develop a 360 degree clinical picture. So then we know what to do inherently because we know what's happening and we know the causes. So again, you can look at G6PD deficiencies, G6PD has survived because it actually has protected people from malaria. So malaria, because it can incubate in red blood cells. The red blood cells actually die before malaria can produce. So that's one of the reasons why it's persisted. Not really needed in the Western world or most of the world now. Cell energy is derived from ATP. Ribose is the substrate. NADPH is needed for neurotransmitters, glutathione, fatty acids, which come from the mitochondria. And I know I wasn't taught this in school. So as I've come across it and studied it all these years, it's an important thing to remember and to keep in mind when you're practicing. So I use a lot of ribose in my practice, and we'll get to how to use that for these things. We know leaky gut, as we've said before, it drives mitochondrial dysfunction. It's one of the main things that drives mitochondrial dysfunction, and it's one of the main detrimental effects of leaky gut. So this study here, or actually I give many studies in this, so you can look at it. And again, this will be recorded, and it'll be posted on the Professional Co-op website, so you can review it. I hope you do. This has taken me a lot of study over the years to really own and master. So, but I am convinced that without addressing the mitochondria specifically, clinical outcomes are going to be limited, especially as patients get sicker and sicker. This world gets more and more toxic and more stressed. So mitochondrial metabolic stress induces mitochondrial dysfunction, which may lead to the disruption of the intestinal epithelial barrier. So what this is saying is mitochondrial dysfunction can initiate leaky gut, but then leaky gut can initiate mitochondrial dysfunction. And so it's a feed-forward loop. The more mitochondrial dysfunction you have, and it will affect the gut quite intensely, because the cells in the gut turn over at a very rapid rate. The requirement for ATP is much higher in the gut than it is in the brain and the heart combined. So ATP, the mitochondrial health, is more important to the gut than anything. But again, if you have leaky gut and infections and other things that trigger the leaky gut, then you're going to have mitochondrial damage. So supporting the mitochondria is essential in healing the leaky gut. And vice versa. So you have to heal the leaky gut in order to treat the mitochondria. This is why studies show multiple sclerosis and lupus and myalgia. Many different autoimmune diseases. We know Hashimoto's. All of this is almost every one of the autoimmune disease patients that study, when their microbiome is studied, it's severely altered. And again, with the research that's been happening in the last 10 years, it's the altered microbiome and the leaky gut that precedes the autoimmune disease. But then the autoimmune disease comes along and makes it worse. So we want to look at the genetic predisposition, the dysbiosis, the environmental factors, medications, toxins, whether they're vitamin D deficient, those kinds of things. In this study, gut bacteria signaling to the mitochondria and intestinal inflammation and cancer. So emerging evidence suggests that the gut microbiome signals the mitochondria, not just to mucosal cells, but to the rest of the body. And that gut microbiome signaling has been shown to significantly alter the mitochondrial metabolism, that activate immune cells, induce the inflammasome signaling, and then further alter epithelial barrier. So that is, running stool tests as well. And this is why we run the tests. We want to look at the microbiome. We don't want to just throw probiotics at it. We want to heal the leaky gut. And I tell my patients this all the time. It takes at least 6 months to a year to repair mitochondria and to repair leaky gut. It doesn't happen in 2 weeks. It doesn't happen after a week or a month of a detox. That's a good start, but there's a lot more that needs to happen. And our job is to be the detective. What else is triggering mitochondrial dysfunction? Ochratoxin A. This is an intestinal toxin from mold, and it's a neurotoxin as well. And so people who eat more ochratoxin from moldy foods, or who are exposed to ochratoxin, or who have mold in the gut, there's a lot of evidence that people, not just yeast, but other mold and fungus that produce ochratoxin. So if someone has elevated ochratoxin and you don't suspect, or you've tested their home and they're not getting exposed to it in their home, then it's likely coming from inside or the diet. But then if the diet's clean and their ochratoxin is still elevated, then it's likely from dysbiosis. And that here is one of the mitochondrial permeability transition pore opening damage that happens through reactive oxygen species. So it creates mitochondrial permeability. So another way of remembering this is intestinal permeability mirrors mitochondrial permeability. And mitochondrial permeability is not what you want. That's damage to the mitochondria. So those two almost go together in every clinical case that I've seen. So environmental neurotoxin can induce dopaminergic neurodegeneration, a potential link to impaired neuroinflammatory mechanisms. So things like Parkinson's disease, it is a mitochondriopathy. We know now that it is a mitochondriopathy. And then we want to find out what's driving that issue. Certainly leaky gut and blood-brain barrier issues are at the cause and core of that. But that allows, once you have mitochondria, once you have leaky mitochondria, once you have leaky gut, once you have leaky brain, and those three things almost always go together, then you're more susceptible to the damage that pesticides, herbicides, and other toxins and dysbiosis inflict. So not being exposed to toxins in and of itself, if you are a healthy individual, a little exposure is fine. The human body is more than capable of dealing with some exposure. We've evolved with quite the robust detoxification and redundant anti-inflammatory systems. But it's when you have leaky guts and you have leaky brain and the mitochondrial damage and nutritional deficiencies, and these things are allowed to aggregate into dopaminergic neurons. Just like we said, toxins love to aggregate around the mitochondria. So they're going to aggregate around dopaminergic neurons. Why are dopaminergic neurons so susceptible? Because they actually produce more oxidative stress than any other neuron. That's one of the reasons why Parkinson's disease and even Alzheimer's is so prevalent, because of this redox issue. Mitoprotective diet. So here we'll kind of start getting into some hints of what we do. Mitoprotective dietary approaches for myalgic encephalomyelitis, chronic fatigue syndrome, caloric fast restriction, fasting, and ketogenic diet. So all of those have been shown to be very well. And when I do very well, and when I say ketogenic diets, and when they study this isn't eating cheese. This isn't what people think of as ketogenic diets. It's more of a paleo diet, not necessarily a high fat diet.
Just 1 second here, Dr. Lundell, and we're about at the 15-minute mark. So
great.
It's all great so
So
far. Thank you so much.
yeah, you bet. Thanks for the heads up. So role of dietary modification in alleviating chronic fatigue syndrome. Again, here's where we start to get into polyphenols, D-ribose, omega fatty acids. These are the things that we use. I don't know if people are using much ribose in their practices. I find that it's pretty underutilized, especially with mitochondriopathies. So if you get nothing else out of today, one, understanding that the mitochondria is at the core issue, and two, ribose is pretty essential for treating leaky gut, for treating leaky brain, for treating methylation and genetic issues and mitochondriopathies. Again, understanding D-ribose and mitochondrial function, supplementing with D-ribose has been shown to improve cellular processes when there is mitochondrial dysfunction. So again, if you have leaky gut and you have mitochondrial issues, then they go together. You're going to have leaky brain as well, and ribose is very important in the literature. Benefit of ribose in a patient with fibromyalgia, a good case study that I saw many years ago, and one of the reasons why I caught on to this and started using it many years ago. Cellular protection during oxidative stress, potential role for D-ribose and antioxidants. So I do them together. I don't do D-ribose just by itself. Normalization of leaky gut in chronic fatigue syndrome is accompanied by clinical improvement, effects of age, duration, illness, and the translocation of lipopolysaccharides. So this isn't the only, we're not the only ones doing this, but glutamine, N-acetylcysteine, and zinc obviously are standards for healing leaky gut, but I would offer today that adding in the ribose, CoQ10, the mitochondrial support, acetyl L-carnitine, those kinds of things are absolutely imperative. Ribose accelerates gut motility and suppresses mouse body weight gaining, so it's actually good for constipation. It's good for irritable bowel disease as well. So I use it in a lot of bowel cases, Crohn's, ulcerative colitis. And we also do high intensity interval training. Not a lot of people with chronic fatigue syndrome can do that, obviously, because they're very tired. So if they have exercise intolerance, which is another clinical indicator of mitochondrial issues, then we want to support them in very specific ways. So support for exercise and or adrenal insufficiency. So adrenals also, when we talk about adrenal insufficiency, what are we really talking about? Are we talking about degranulation of the medulla? No, actually we have enough epinephrine and norepinephrine to last, I don't know, there was a Stanford researcher that showed most humans have enough epinephrine and norepinephrine to last 30 lifetimes. So it's not that, it's the cortex and those layers that don't undergo degranulation, but it's actually a mitochondriopathy. The mitochondria become dysfunctional and the cell cannot make cortisol and DHEA and those things. So so this is what we use for adrenals and exercise, and also for mitochondriopathy. So ribose, CoQ10, acetyl L-carnitine, adaptogens, pregnenolone. You can do some adrenal glandulars specifically for exercise intolerance, nitric oxide support, things like arginine and citrulline, and cranberry extracts and beet extracts and things, vitamin C, and then again, branched chain amino acids. It's one of the reasons why athletes still benefit from branched chain amino acids. They recover quicker because it supports the mitochondria. I like rhodiola and cordyceps. Those are two of my favorite adaptogens, and we see some good evidence and specifically how it affects the mitochondria. So quick case study. This is my super panel, and again, we can look at the super panel numbers. I don't know if Bill, you have those numbers, but you can contact Professional Co-op and just ask for Dr. Lundell's. This is my super panel 1, what I call like the deluxe panel. This is what every new patient, this is minimum that I run in every new patient. So in this patient, we see glucose being a little bit high and hemoglobin A1C actually being low. What this is, and I don't have time to get too much into the biochemistry, but if you see high fasting or high fasting glucose, but still low or normal hemoglobin A1C, that's an indicator of mitochondriopathy.
So
And that is, yeah.
I'll just chime in for 1 second again, Dr. Lundell. Yeah, the ordering code for that panel, it's the largest panel we have in the system, 76520, and you can just type Dr. Lundell's last name, Lundell, into the search bar on the requisition page, and these panels will come right up for you. Click on the ordering code, and all the panel elements and a whole lot of other stuff will come up in that box as well. So excuse the interruption.
Nope, thank you. This is standard for my new patients, and a lot of my students use it as well. So in this one, I downloaded one. The magnesium red blood cell wasn't there, but the number was actually like 4.8. So low red blood cell magnesium is also an indicator of mitochondriopathies. We want red blood cell magnesium to be greater than 6. And if you go to my website and if you download my lab manual or sign up for my courses, then I do case studies. I'm going to start a nutritional pathology group forum, and we'll just go through. I just go through case studies like this and go through the labs. It's the best way to learn how to do this stuff. So, but you can see the creatinine is low in this patient. That's also sometimes another sign of mitochondriopathy. Now, if it's really affecting the kidney and they have chronic kidney disease, then obviously the creatinine is going to be high. So one of the most crucial things of understanding about diagnosis from a functional medicine standpoint is that no single analyte is enough to make a diagnosis, or very rarely, except maybe high homocysteine or low vitamin D, those obvious things. But if there's truly an underlying biochemical, physiological altered process, you're going to see it in several different analytes, and not all of them are going to be there in the same pattern. So I also have the pattern guide that you can download as well from my website. So I will go through a lot of these. So I'll just go look at the bottom for creatine kinase. So creatine kinase is a specific marker of mitochondrial health. Now, you have to understand, if it's high, that means there's a lot of inflammation, which can also be from mitochondriopathy. But if the creatine kinase is low, that's telling you the patient is in a low mitochondrial state. The mitochondria is not functioning well because creatine kinase is actually a byproduct of cellular respiration in the Krebs cycle and in the mitochondria. The other one is LDH. And you can see this patient had relatively low creatine kinase. I like to see creatine kinase in most healthy people above 100. Now, we don't want it above, 150 or 160, because that could lead, tend to, say that there's too much inflammation and damage and destruction to the cells. But low creatine kinase, can also be this mitochondriopathy. So to say it in another way, both low and high creatine kinase can be an indicator of mitochondriopathy. LDH, she's at 119. That's another mitochondrial enzyme. So if the LDH is low, then this patient is likely, and none of these are pathognomonic, definitive, but they give you a clue. She also has relatively low ALT, and GGT, and that's a B6 deficiency. These are B6 dependent enzymes. The iron is a little bit high, and so that could also be toxic exposure, the mitochondria not utilizing the iron and the oxygen well. The vitamin D is actually not too bad. A healthy long-term level of vitamin D is around 40. There's definitely reasons to have it higher short term, but when we look at all-cause mortality long term, vitamin D should be around 40 to 50 at the most. And you can look at cholesterol, thyroid. Thyroid is another heavy mitochondrial dependent gland, and so her triiodothyronine, or T3, is very low. And look at her homocysteine. Her homocysteine is actually a little bit low too. So in this patient, I will run a SAMe test to make sure that she's getting enough SAMe, because she may not be producing enough SAMe, and so then there's not enough SAMe that gets turned into homocysteine. So low homocysteine is also not good, or potentially not good. So then we look at her, fortunately, her antinuclear antibodies were negative, but that's not pathognomonic either. Her RA latex or fibrinogen activity was actually a little bit low fibrinogen activity. And I know I'm going through a lot here because we're just about out of time, but low fibrinogen activity is can be an indicator of dysbiosis and leaky gut. And high fibrinogen activity is a lot of cardiovascular inflammation. So then we run a urinalysis, which you have to add as a separate code. But we run a microscopic, because look down here, she has a few bacteria. If that was a clean catch, which, you know, I instruct my patients in how to do that, and LabCorp should as well, then that bacteria shouldn't be there. So a lot of times patients will have this low-level chronic bladder infection or leaky bladder, and that's something that needs to be addressed as well. So just in the last couple minutes I'll go over some synergistic nutrients for the mitochondria. I already kind of alluded to some. I'm not the first one to come up with this. Steven Sinatra has been around forever. Very famous for his heart research, cardiovascular research. But he even says D-ribose may not be as well known as its fellow awesome foursome that he calls them: CoQ10, L-carnitine, magnesium, and D-ribose. That's like minimum for his cardiovascular and brain support as well. But that's my minimum. That's something that should be added in for leaky gut. Again, leaky gut is a mitochondropathy, and so we want to treat that with as many different nutrients as possible. Lipoic acid is also one that I treat, that I use on a daily basis in my practice. Effects of alpha lipoic acid on multiple cytokines and biomarkers, and the recurrence of AFib within 1 year of ablation. I tell you, my dream, like most of you out there, is to have a truly integrated medical system. If we were to combine the best of Western medicine, if someone does get an ablation, but they do N-acetylcysteine, and there are studies. I have a cardiovascular module that I go into in module 6 in my functional medicine classes that show that there are some hospitals out there doing this, that they will actually give IV N-acetylcysteine and lipoic acid, and their outcomes are 100 times better. So after 1 year, 5 years. So anyway, that's my dream. But we just this is why I love teaching and getting this out there. So the research is there. The research is there. It's just presenting it. So I also do grapeseed extract, grapeseed proanthocyanidins or proanthocyanidins. Grapeseed extract is a really, really important one that I use. And again, this study shows that just using grapeseed extract increases NADPH because it protects the mitochondria. And if you go to my YouTube channel, I've got a really good lecture on polyphenols. You can look it up on YouTube. You just type polyphenols, Dr. Lundell, and I give a good review of what polyphenols are and what they do. Again, the use of NAC in patients undergoing cardiac surgery should be strongly recommended. That's what these authors are saying. So that's why my patients keep coming back too, because no matter what is going on in their life, we can support it with natural medicine. So some L-carnitine in heart disease, randomized placebo-controlled trial for acetyl-L-carnitine and dementia, very good results. Taurine is also very good. I don't know if I can mention any specific supplements, but if you want to email me at hhc@drbrandonlundell, I'll give you that in a second. I can give you the specific ones that I use. Taurine reduces CRP and is actually really good for exercise and for leaky gut and the mitochondria. So here's some suggested dosages for ribose, and I can give suggested dosages for the others as well. But these are just some of the things that I use for ribose. You do have to use, a fair amount. 1 gram probably isn't going to be enough to treat leaky gut, but 2 to 4 if you're healthy can help support. So that's what I wanted to cover today. And believe me, this is just the tip of the iceberg. But if you want to know more about this stuff and how I use this information in the research to really drive clinical practice, please look at my classes, Nutritional Pathology and Functional Medicine. This is about 10 years in the making or more. I've been collecting this research, doing this and teaching for over 10 years. I developed a class at Southern California University of Health Sciences as well. So, and I just keep refining it and providing more information every year. So it's 6 modules. It's your own pace. You get to download it. I'm going to be doing a live class online here in the next couple months. So you can look that. But if you want to get started and download it now, if you email me this week, I will give you a $500 off certificate. And I would do it now because my prices are going to go up quite significantly at the beginning of the year. Well, if you download this now, then what you can do when I give my other course, live course, I give everyone who's purchased the course half off of the live courses.
Well, so thank you for a really great presentation for people to understand and get started with here on the very difficult subject of autoimmune.
Yeah, it is.
Now we know why you came up with this mantra that good doctors know what to do, but great doctors know why. And understanding the why part of it is extraordinarily important. And to that end, we've got some actually pretty good questions here.
Okay.
You want to take a shot?
Yep, go for it. Do you want to read them to me?
Oh, yeah, sure. Okay. Can you comment on mast cell activation in autoimmune issues?
Yeah, so mast cell activation, it's a secondary issue. So just like we showed in the neutrophil, mast cell activation is a mitochondriopathy. It's another manifestation of a mitochondriopathy. There was that study at the beginning of this webinar that showed what happens to neutrophils, and it actually increases the inflammasome, interleukin-1b, tumor necrosis factor alpha. So it's an inflammatory issue. You almost always have to treat the mitochondria when you see mast cell activation syndrome. Now that's a difficult one to diagnose. We run homocysteine, you can run, or serum histamine, you can certainly run that. CRP is another potential marker for mast cell activation syndrome. High or low neutrophils, that's the clinical symptoms of rashes and hives and fatigue after eating, bloating after meals. That's not always SIBO as people attribute that to. That can be mast cell, a deficiency of enzymes, histamine deoxidase, diamine oxidase, a deficiency of that. So but remember, MCAS is a secondary diagnosis. That's not a primary diagnosis. So you have to get at the causes.
And next, how high is high RDW?
Yeah, it depends on whether they're menstruating female, non-menstruating female, postmenopausal, males. They're going to be different ranges. You'll have to, you can look at my manual for those ranges. I give male, female, and age ranges for some of those. So, it depends. Certainly anything above, 13, 14 for most people are going to catch my eye. And then I'll kind of look for some of the other clues that's happening. Again, homocysteine, CRP. You can look at hematocrit, red blood cell numbers.
Maybe reticulocyte count as a follow-up test as well.
What's that?
Reticulocyte count maybe as a follow-up in some cases.
Exactly. Yeah, exactly.
And the lab range is, I think, 15.4 on the high end. I think we're going to really agree that that's too high, that once it gets above 14, maybe 14 and a half, we're going to have to look for something.
Exactly. Yeah. And don't just throw vitamin C at it. Most people just throw vitamin C. It's an indicator of mitochondriopathy. It could be.
Do you use NADH in your practice? And if so, what doses do you recommend? I think that was asked and answered, but
With the NADH?
yeah.
Yeah, so I do refer sometimes to NAD IVs, but most of the time I use a sublingual NADH, and I'll use, it depends on the patient. I'll use anywhere from 200 to 1,000 milligrams.
Excuse me. Okay. Could mitochondriopathies be due to or be a cause of high ferritin in the absence of hereditary hemochromatosis?
Yeah, absolutely. Remember, ferritin is an acute phase reactant. So that means that there's damage, usually in the liver specifically. It's hard to get high ferritin if there's not active damage in the liver. So then you have to ask yourself, what's happening? Is it iron accumulation? Why is there iron accumulation in the liver? It could be fatty liver. It could be cytomegalovirus or Epstein-Barr or some other infectious process. But what overwhelms the liver the most for most people in the absence of a severe disease like that is leaky gut, because again, the gastropatoportal system, it goes right, all those microbial products and all those toxins from leaky gut go directly into the liver, and over time create damage in the liver. And so, yeah, high ferritin is absolutely an indicator, not necessarily of just a mitochondriopathy, but there's almost always a mitochondriopathy when we're dealing with some kind of liver issue. You just have to be, a little bit more investigative about what's happening there. So run your CRP, run your cytomegalovirus, run some other tests to see what's happening in the liver.
Okay, and
one other thing about that though, what I would say is that high ferritin is an indicator that the mitochondria are under a lot of stress, meaning that high iron will cause more stress on the mitochondria. So certainly getting that addressed is really important to protect the mitochondria.
Okay. Here's a kind of a basic situation question. How do you sequence the treatment plans for complicated patients with multiple system dysfunction, i.e. mitochondrial issues, inflammation, hormone, autoimmune, nutritional deficiency, that sort of thing?
Yeah, that's always a good question. And the basic answer to that is always, you can't go wrong treating the gut first. We know that intestinal permeability mirrors mitochondrial permeability, and the treatments are essentially the same. So always be working with that in the beginning. You could be working on the hormonal issues at the same time, and the adrenal issues. They all have to go together. But of course, the nice thing about sort of understanding functional medicine as holistic medicine as well is that you don't have to treat everything all at once. At the same time, you start with some of the most pivotal pieces, and certainly leaky gut and the mitochondria are at the core, and then everything else you do. If you're working with adaptogens, if you're working with exercise, if you're working with those things, other treatments, then those hormones are going to work better, and everything's going to work better. I can promise you, if you address the mitochondria and leaky gut first.
Okay. We'll do one last question here. If one has an infection, how much ribose to prevent the bugs from overgrowth?
Well, so ribose in and of itself is not an antimicrobial per se, although the good news about ribose is it's not used by bacteria as an energy source. So it's not going to feed SIBO, or it's not going to feed yeast, which is great. But per se, it's just part of healing the leaky gut and fixing the terrain, the soil, while you sort of pull the weeds and replant good garden and probiotics. So it is part of my dysbiosis protocol, but that's because leaky gut is part of my dysbiosis protocol. So so healing leaky gut, to answer the question sort of in a roundabout way, not how do we use ribose to treat infections in the gut, but as part of the leaky gut, I will do 4 to 8 grams a day. Depending on the person, depending on, how much they can tolerate. I use a product that has acetyl L-carnitine and taurine in it, and it's a chewable, so they could either swallow it or chew it. So I'll usually, and 1 tablet is about 1 gram of ribose. So, so I'll do 2 twice a day or 4 twice a day, that kind of thing.
Okay, let me just remind folks that in 2 weeks, on the 23rd of September, at the same time, 1 p.m. Eastern, we have Dr. Rob Silverman who's going to talk about long-haul COVID, a big topic now where we're not out of this by any stretch, so that would be a great one to watch. And also on the 30th of September, we have Dr. Rob Kessinger, really amazing presenter as well, who's going to talk about blood chemistry patterns to look for. So those are a couple upcoming things we have coming. Someone asked Dr. Lundell, what is the discount code you gave? I'd like to hear that again.
Just email me at the bottom there, HHC, Dr. Brandon Lundell, and I'll give you guys the code for $500 off. I change it every week, so just email me and I'll, if I'm giving a lecture, just email me and I will give you the code.
And thanks so much, Dr. Lundell, for a really enlightening and awesomely referenced with clinical application on this topic of autoimmune and mitochondrial dysfunction. Thanks so much for being part of what we do here. And please go back and watch some of Dr. Lundell's other presentations because they're very much worth your time.
Thank you, Bill, and thanks for everything that you do and being part of the functional medicine, movement to uplift the world. So thanks for having me.
Well, it's our pleasure. Thanks again, and thank you all for attending. We very much value your time, and we hope you got tremendous information from this. Have a wonderful day. We'll see you again soon.
Bye, everybody. See you next time.